The thoracic spine consists of 12 vertebrae. The articular processes are orientated in the coronal plane, affording the thoracic spine with a large degree of flexion and some extension. Movements are generally restricted by the binding effect of the thorax and the sternum anteriorly. The ribs articulate with the sides of the vertebral bodies and with the transverse processes. Examination of the thoracic spine begins with observation. Note the anteroposterior and lateral curves. In particular, check for scoliosis, kyphosis, or pectus deformities, and the reciprocal distortion in the normal rib appearance. Let your hands loose by your sides. The patient should be observed sitting, especially if scoliotic. If the deformity is functional or related to pelvic or leg discrepancies, then sitting will eliminate this. If permanent or structural, there should be little difference noted. Please remember to refer to the guidelines stated in the general observation section. Palpate over the spinous processes and paraspinal muscles. Feel for presence of abnormal bony contours of the spinous processes and interspinal spaces. Any area tender?
No.
Get them to perform flexion, extension, rotation, and lateral flexion. Drop your head down and go as far as you can. That's fine. So as far as you can go. And then slowly back up. Now, can I get you to arch your back all the way backwards? That's fine, thank you. If the patient is standing, the examiner should immobilize their pelvis in order to assess rotation. I'm trying to look back, and I'm going to fix your pelvis here. That's fine. The other way. That's fine. Now straight ahead. I'm going to get you to bend to one side by dropping your arm down like that. And now the other way. That's fine. Thank you. Passive assessment of the thoracic spine is normally performed in the sitting position, but for practitioners of manipulative therapies, the sideline position can also be adopted. Ask the patient to bring both hands behind the base of their neck, with the elbows close together, facing forward. Place one hand to support the weight at the front, and with the other to palpate the spine. Encourage them to drop their weight anteriorly whilst you move their thorax posteriorly. Now I'm just going to do it again. This time I'm going to push you slightly further up. Side bending can be achieved by placing an oblique downward force over their shoulder with the force directed towards the opposite side of their pelvis. For rotation, ask the patient to hold their arms together in front of them. Stand from behind or to their side. Rotate their thorax to the right and to the left, whilst your free hand palpates the spinal segments. In performing passive movements, try to evaluate the range of movement, resistance, quality, and segmental variations. Feel for any palpable phenomena, including crepitations and popping sounds. Compare the range achieved with active movements and note any variations in reported symptoms. Active resisted movements of the thoracic spine are seldom performed. If you wish to do this, use the same position as with the passive movements. If there is a need to observe how the patient is able to perform functional movements, then ask them to bend forward to pick something up, to lean over to one side, to twist around to the side and reach for an object, to cough and to blow out forcefully.